Good afternoon. My name is Holly Montejano. I am a clinical science liaison with PDI Healthcare, and today we're going to be talking about hand hygiene in the healthcare setting. First, we'll start out with the objectives of this talk. The learner shall be able to define the relationship of hand hygiene to healthcare-associated infection, or HAI burden, discuss the importance of hand hygiene in the reduction of HAIs, outline the evidence and guidelines for hand hygiene, review the hand hygiene basics, such as when to perform hand hygiene technique, and special considerations of gloves, multi-drug resistant organisms, and Clostridium difficile. Just to briefly provide you with some definitions of some of the terms we're going to be using, I'll present this slide. I'm not going to go over it in great detail, as many of you are already familiar with these terms, but it will be available as a reference. So just to delve right in, definition of a healthcare associated infection, or an HAI, they're also sometimes referred to as nosocomial or hospital infections, is an infection occurring in a patient during the process of care in a hospital or other healthcare facility, which was not present or incubating at the time of admission. This includes infections acquired in the healthcare facility, but appearing after discharge, and also occupational infections among healthcare workers of the facility. So why is hand hygiene so important? Just to kind of first go over the worldwide burden of healthcare acquired infections, estimates are hampered by limited availability of reliable data, oftentimes outside of the United States and Europe. The burden of disease both outside and inside healthcare facilities is unknown in many countries due to limitations with data reporting. No healthcare facility, no country, no healthcare system in the world can claim to have solved the problem of the HAI burden. Estimated rates of HAI worldwide, we know that they impact hundreds of millions of people and are a major global issue for patient safety. In modern healthcare facilities in the developed world, about 5 to 10% of patients acquire one or more infections during their hospital stay. In developing countries, the risk of HAI is 2 to 20 times higher than in developed countries, and the proportion of patients affected by HAI can exceed 25%, which is, if you think about it, truly astronomical. In intensive care units, HAIs affect about 30% of patients, and the attributable mortality can reach as high as 44%. So this beckons the importance of hand hygiene. We know that this is one of the basics and foundations of infection prevention. So in the United States, we know that infections are a very serious problem in our healthcare facilities. About 1 out of every 25 hospitalized patients will get a hospital-acquired or associated infection. In 2011, there were an estimated 722,000 HAIs in U.S. acute care hospitals. And of those, about 75,000 die from their infection. So when you think about that, if you want to put it into terms that are truly staggering, you could equate that to about 340 commercial airliners crashing annually. Many infections are transmitted on the hands of healthcare personnel, oftentimes preventable if hand hygiene were done appropriately. So hand hygiene can reduce the transmission of HAIs to the patients, certainly, but we shouldn't forget that they can also protect us as a healthcare worker, and any germs that we may bring home to our family. It could prevent that. This is just another infographic kind of highlighting the same information we just discussed. One additional piece is that more than half of all hospital patients receive antibiotics. That's a whole different talk in regards to antibiotic stewardship, but certainly it can play into some of the HAIs if you're considering multi-drug resistant infections, Clostridium difficile infections, that sort of thing. And again, this is just to kind of review the overall 722,000 patients that are impacted by HAI as of 2011. It gives you kind of the breakdown by major site of infection: pneumonia, GI illness, UTIs, primary bloodstream infections, surgical site infections, and then a group of other types of infections, totaling about that 722,000. So the most frequent sites of infection and their risk factors. So UTI, lower respiratory tract infections, surgical site infections, and blood infections are the most common sites of HAI and their risk factor for occurrence of infections. And really, many of these infections can be tracked back to just an overall lack of hand hygiene. They truly are preventable a majority of the time. So we know that in terms of infection transmission via the hands, hands are a common vehicle to transmit healthcare associated pathogens. Transmission of healthcare associated pathogens from one patient to another via healthcare worker hands actually requires 5 sequential steps that we'll discuss in detail. So hand transmission step 1, the germs are present on the skin. To the order of millions of colony forming units. Our hands then contaminate the patient environment. And just to kind of give you an idea, germs present on intact areas of some patients' skin can be, like I mentioned, in the 100 million colony forming unit counts. Nearly 1 million skin squams containing viable germs are shed daily from normal skin. These germs are ubiquitous on us, they're ubiquitous in the environment. And of course, the patient's immediate surroundings, such as their bed linens, furniture, objects in their immediate patient environment, can become contaminated by their own germs or germs of other people. So step 2 of transmission, by direct and indirect contact, patient germs contaminate healthcare workers' hands. Some examples of how nurse hands pick up microorganisms even while performing clean activities. We see that, 100 to 1,000 colony forming units of Klebsiella particularly can be picked up lifting patients, taking the patient's pulse, their blood pressure, or oral temperature. 15% of nurses working in an isolation unit carried a median of 10,000 colony forming units of Staph aureus on their hands. Again, just speaking to how ubiquitous these organisms are in the patient care environment. And in a general healthcare facility, 29% of nurses carried Staph aureus on their hands, with a median count of 3,800 colony forming units. And 17 to 30% carried gram-negative bacilli also, with median counts of 3,400 to 38,000 colony forming units. Step 3 of hand transmission, germs survive and multiply on healthcare worker hands. So following contact with patients and or contaminated environment, germs can survive on hands for differing lengths of time, as short as 2 minutes, as long as 60 minutes, maybe even longer for certain organisms. In the presence of hand hygiene action, the longer the duration of care, the higher the degree of hand contamination, which would make sense. Step 4, defective hand cleansing results in hands remaining contaminated. So if hand hygiene is not performed appropriately, or insufficient amount of product and or insufficient duration of hand hygiene can lead to poor hand decontamination, thus increasing the risk of perpetual transmission. It should be noted that transient organisms are still recovered on hands following hand washing with soap and water, whereas hand rubbing with an alcohol-based solution has been proven significantly more effective. And we'll touch on the alcohol-based hand rubs a little later in this slide. And finally, step 5 of transmission. So we have the germ cross-contamination between patient A and patient B via the healthcare worker's hands. And if appropriate hand hygiene is performed between patient A care and patient B care, of course, that would thwart the spread. Manipulation of invasive devices with contaminated hands determines transmission of patients' germs to sites at risk of infection. So certainly, if you're caring for any sort of indwelling device, the patient would be at increased risk for infection if adequate hand hygiene is not performed. So this was an interesting schematic or study, multiple studies actually listed in this chart, highlighting the compliance or lack of compliance rather with hand hygiene in different healthcare facilities. And these studies are older, but I'm sure a majority of them would hold to today as well in terms of representation. We know that hand hygiene is not performed when it should be, and the report from this chart shows that, basically less than 40% of the time is hand hygiene performed appropriately. And this represents varying unit types within various facilities. So University Hospitals of Geneva in 1999 kind of highlighted the risk factors for poor hand hygiene compliance, listing that as morning and weekday shift, high risk of contamination, being a physician, and working in intensive care. So again, these are all risk factors for poor hand hygiene compliance. Main reasons for non-compliance reported by the healthcare workers in this study was that they were either too busy to perform hand hygiene, the hand hygiene product caused skin irritation, they were using gloves, or they just didn't think about the appropriate moment for hand hygiene. Time constraint has been reported as a major obstacle for hand hygiene. Adequate hand washing with water and soap requires about a 40 to 60 second practice. The average time usually adopted by healthcare workers is less than 10 seconds. So that's certainly not an adequate amount of time for that removal of organisms from the hands. Other relevant obstacles in some settings, lack of access to sinks and lack of continuous access to clean water, soap, and paper towels at the point of care. And we know that certainly if a hand hygiene station or hand hygiene product is not available without barrier, oftentimes the healthcare worker will not choose to perform hand hygiene. Kind of to provide a brief history lesson at this point, I wanted to review Ignaz Semmelweis, who's considered the father of hand hygiene. He was employed as a physician at the Vienna General Hospital from 1841 to 1850. And in 1847, Semmelweis observed a link between high maternal mortality rates due to puerperal fever and hand washing. He found that doctors and medical students were coming directly to the delivery suites after performing autopsies. They were noted as having a disagreeable odor on their hands, even though they were washing with soap and water. He hypothesized that these cadaverous particles from the autopsy room were transmitted via the hands of doctors and students to the mothers in the delivery suites, which caused puerperal fever. Semmelweis recommended that hands be scrubbed in a chlorinated lime solution before every patient contact, and particularly after leaving the autopsy room. Following the implementation of this measure, the mortality rate fell dramatically. This was the beginning of a new era in patient safety and hand hygiene. And this next slide kind of highlights the two different clinics and the intervention as of May 1847, the subsequent reduction in the percentage of maternal mortality rates once adequate hand hygiene had been introduced. Now to touch on the chain of infection and hand hygiene. So this is a very detailed slide provided by APIC, highlighting the importance of breaking the chain of infection. So the chain of infection includes an infectious agent, a reservoir in which the agent can sit and survive and reproduce, a portal of exit, a mode of transmission, a portal of entry, and finally a susceptible host in which to infect. And basically, how do we break that chain of infection? Well, this is what we specialize in terms of infection prevention. So we have standard precautions, which applies to the care of all patients. And basically, by definition, we assume all blood, body fluids, secretions, excretions, except for sweat, non-intact skin, and mucous membranes may contain transmissible infectious agents. Hand hygiene is a foundation of standard precautions. PPE use as well, so gloves, gown, mask, eye protection, or face shield, depending on the anticipated exposure the staff member may have, and certainly safe injection practices. Then a tier above standard precautions, we have the transmission-based precautions, and these are applied when there is a known or suspected infectious agent requiring additional control measures. And I'm sure, as you're all aware, the transmission-based precautions consist of airborne precautions, droplet precautions, and contact precautions. So hand hygiene regulations and guidelines. There are 4 primary agencies providing regulatory oversight for hand hygiene programs in the United States. CMS, or Centers for Medicare and Medicaid Services, OSHA, which is the Occupational Safety and Health Administration, FDA, the Food and Drug Administration, and finally CPSC, which is the Consumer Product Safety Commission. And certainly hand hygiene compliance can certainly impact accreditation and reimbursements for these facilities. World Health Organization and the Centers for Disease Control and Prevention, or CDC, provide some great online guidelines for hand hygiene. There, in 2014, SHEA IDSA issued a practice recommendation in their ICHE, their professional journal, strategies to prevent healthcare-associated infections through hand hygiene. And basically, what this table 1 shows, CDC and World Health Guidelines are basically in agreement when it comes to, the appropriate indication for performing hand hygiene. And you can kind of look down the list for the CDC guidelines and when to wash hands, and the World Health Organization guidelines. And you can see they're both basically saying yes. Some particular or special updates: overall alcohol-based hand rubs, or ABHRs, are still more effective than soap products against bacteria and viruses. 12 out of 13 studies showing to be more effective than soap against bacteria. One study was actually equivocal. Alcohol-based hand wipes with at least a 65% alcohol are now showing to be comparable to alcohols delivered by other dispensing methods, and we'll delve into that in a minute. Alcohol-containing hand wipes offer a convenient option for bedbound patients, first responders, and others who cannot easily get to sinks or wall-mounted dispensers. Just want to go back. Alcohol concentrations for the alcohol-based hand rubs should be between 62 and 95%. I just wanted to note that since it's not on the slide. And then the application time of hand hygiene and reduction of bacterial contamination, you can see that after 15 to 30 seconds, alcohol-based hand rub is significantly more efficient than hand washing with plain soap and water to reduce the bacteria on hands. And some updates regarding special pathogens. If you're dealing with norovirus, certainly focus on glove use and hand hygiene, appropriate hand hygiene practice. As we know, norovirus is incredibly infectious and can easily propagate once introduced into a healthcare facility. There is a lack of substantial evidence showing product, so whether or not soap and water or an alcohol-based hand rub is preferred. In terms of Clostridium difficile infection, there is definitive proof showing gloves are very important in decreasing Clostridium difficile infection transmission. The evidence is still inconclusive about which product is best in the clinical setting for performing hand hygiene. Soap and water does offer a slight advantage over alcohol-based hand rubs in vivo studies, and the recommendation by CDC is to use soap and water with an emphasis on gloving. Certainly we know that soap and water provides that mechanical removal of the spore. The overall recommendation for norovirus and Clostridium difficile outbreaks, or hyperendemic Clostridium difficile infection, is to use contact precautions requiring glove use as well as gowns, and using soap and water after caring for patients. So what should we not be doing in terms of our practice with hand hygiene? Do not use hot water for hand washing because it can irritate the skin. Do not use alcohol-based hand rubs when hands are visibly soiled. We know that. Do not use triclosan-containing soaps. There's a lack of evidence supporting its effectiveness compared with chlorhexidine gluconate soaps or alcohol-based hand rubs. There's a potential to promote antimicrobial resistance also with the triclosan. Do not use self-report as the primary method of hand hygiene adherence measurement. Use direct observation, product volume measurement, automated systems, or a combination of strategies to measure compliance. And certainly it is very important. It may be shocking to know what your true hand hygiene rates are at baseline before implementing a hand hygiene program, but that's certainly how you can measure your win once education has been done to bring that hand hygiene compliance rate up. In terms of some new evidence, so there was an article published in American Journal of Infection Control in 2017. Can improving patient hand hygiene impact Clostridium difficile infection events at an academic medical center? And basically what this article looked at was the use of a alcohol hand wipe. It was a single center study performed at a 495-bed university-affiliated medical center in a large healthcare system between November 2013 and December 2015. It was carried out in 2 phases, 4 medical surgical nursing units initially, and then it was rolled out to the entire hospital. The educational program for staff and patients was provided for hand hygiene. Prompting and compliance tools were also utilized within this study. Again, they use a prepackaged 65.9% alcohol hand wipe. They were made available at the patient's bedside during room setup for those patients unable to get to the sink, so essentially those patients who are bedbound. They found that standardized infection ratios for healthcare onset or HO-C. diff lab ID events obtained using CDC's NHSN data were actually statistically significantly decreased after the implementation of these wipes for the bedbound patients. The authors concluded that improving hand hygiene in general influences Clostridium difficile infection incidence. Similarly, although the alcohol wipes may not kill C. diff spores, improved compliance of patient hand hygiene may potentially assist in controlling Clostridium difficile events in the hospital patient or the hospitalized patient. Although alcohol is not considered to be an effective agent for killing C. diff spores, it can be theorized that the alcohol wipes provided a mechanical cleansing of the patient's hands, which removes organic debris and potentially the spores from the skin surface. And again, just to revisit some of the hand hygiene basics, we know that clean hands are important. They save lives. We need to be performing hand hygiene. So why should we clean our hands? Well, any healthcare worker, caregiver, or person involved in patient care needs to be concerned about hand hygiene. So it concerns all of us. And again, not only are we protecting our patients first and foremost, but we're protecting ourselves from these pathogens. We're protecting other visitors in the facility, our colleagues, and certainly our families at home. You must perform hand hygiene to protect the patient against harmful germs carried on your hands or present on their own skin, the patient's own skin, and certainly protect ourselves. Again, can't stress that enough, and the healthcare environment from harmful germs. So the golden rules for hand hygiene. Hand hygiene must be performed exactly where you are delivering healthcare to patients. So essentially at the point of care. It certainly helps to have hand hygiene product available within the immediate patient environment or the patient zone. During healthcare delivery, there are 5 moments or indications when it is essential that you perform hand hygiene. And again, this is a direct reference to the World Health Organization's 5 moments for hand hygiene model. To clean your hands, you should prefer hand rubbing with an alcohol-based formulation if available. And why? Because it makes hand hygiene possible right at the point of care, so you don't have to walk over to a sink to perform soap and water hand hygiene. It is faster, more effective, and better tolerated. You should wash your hands with soap and water when your hands are visibly soiled, and you must perform hand hygiene using the appropriate technique and time duration. And to revisit the 5 moments for hand hygiene if you're not aware. Again, this is a World Health Organization model. Moment 1 would be before touching a patient. Moment 2 would be before performing a clean or aseptic procedure. Number 3 is after a body fluid exposure risk. Number 4 is after touching the patient. And finally, number 5 is after touching the patient's surroundings. And many healthcare workers find this World Health Organization model for hand hygiene to be very intuitive when they're providing patient care as to when they should break and perform hand hygiene before moving to their next task. And again, this is just the 5 moments for you to refer to. Just to touch on alcohol-based hand rubs, again, they are the preferred method for hand hygiene in most situations. Any exceptions would be if your hands are visibly dirty or contaminated, after exposure to a spore-forming bacteria such as Clostridium difficile, and certainly after using the restroom. This is a nice infographic on how to use a hand rub. I won't go through it, but typically the alcohol-based hand rub would be about a 20 to 30 second act. Using the hand rub in a wipe, again, this is an 8-step process, and it is highlighted in this infographic. And finally, if you choose to do soap and water for your hand hygiene, this requires about a 40 to 60 second act, following all of those illustrated steps. Moving into hand hygiene and glove use. Now, we know that gloves and hand hygiene, when they're paired together, equals clean hands, but certainly gloves are not a substitute for hand hygiene. So one without the other will lead to germ transmission. Can't stress enough, always perform hand hygiene before and after glove removal. And this is kind of a nice summary slide providing additional resources, the website for CDC's Clean Hands Count campaign. And certainly, like I mentioned earlier on in the presentation, World Health Organization has a very robust resource base for toolkits, as does Centers for Disease Control, or CDC, as well as APEC. And that today concludes our presentation. Thank you so much for your time.